Did you know that vaginal dryness affects over 80% of vagina owners? It's a silent epidemic that many women suffer from in silence. The hormonal changes that come with peri and postmenopause, especially the loss of estrogen, can cause a variety of symptoms that significantly reduce the quality of life and cause discomfort in the sexual sphere. The other really bad news is that only 4% of those affected are currently receiving viable treatment. This is mainly because there's a lack of coverage of this problem in society, and specialists in women's health are not as active in detecting symptoms of vagina atrophy. Patients are often too embarrassed to discuss intimate complaints with a specialist, which makes it challenging to verify the diagnosis in 75% of cases. Some patients even consider these symptoms as a natural aging process that do not seek help for it. Today, we want to start the conversation about this condition and the importance of seeking help. It is time to break the silence and provide support to the women who are suffering from these oftentimes debilitating symptoms. I'm excited to introduce two women who are experts in this field and who are passionate about helping women reclaim their vagina health. Kim Vopni and Shirley Weir. Kim Vopni is a self-professed Kegel maven and is known as the Vagina Coach. She is a certified fitness professional who became passionate about spreading information on pelvic health after the birth of her first child over 18 years ago. She's the author of Your Pelvic Floor, which launched in March 2020 and was on the bestseller list immediately. Kim offers pelvic health programs and coaching for women and is also a menopause support practitioner. Her Buff Muff app is an ever-growing community where people from around the world find support through her 28-day challenges and monthly membership. You can find her online through her podcast, Between Two Lips, her website, www.vaginacoach.com, and social media at Vagina Coach. Shirley Weir introduces herself as a menopause chick. Sore boobs, sleep deprivation, depression, and brain fog led Shirley to her doctor's office, the bookstore, and of course, Dr. Google. But she was left feeling confused, overwhelmed, and alone. So she created Menopause Chicks to empower women to talk openly about perimenopause and menopause. Now she leads a private online community with an average of 15,000 questions and comments every month. Women regard the group as a trustworthy space to get their questions answered and to confirm they are not alone. You can find her at menopausechicks.com and at menopausechicks on social media. Ladies, welcome to the show.
Thank you so
Hi,
much.
thank you.
Yay. So I met Shirley. I've met Kim before because Kim's been on my podcast many years ago talking about pelvic health. And I am going to link to that first episode in the show notes so you guys can go back and listen to it. But I met Shirley and Kim in person, actually in Vancouver recently for a wellness show. And the two of them did this amazing talk all about vagina health. And I was so happy that they did that. I was in the audience just sitting there super excited. I was like, I just want to get up and talk with them. I want to talk about this too. But it was great. You guys did a great job. And I was so like, everybody received it really well. Like, I can't believe how many of those women were like raising their hand, asking questions. And I'm like, yes, this is it. We need to be getting this out there. So I'm really happy that we're going to talk about this today because, as I said, 80% of women get this and 4% are actually getting proper care, which, that's so depressing, isn't it?
Very,
Very.
very.
Yeah. And you know what, Shirley, like the fact that you have 15,000 questions and comments coming in, like that's great. And it makes me so happy that that you have that space. But then at the same time, I think, oh, how sad is that there's that many questions being asked because we're not getting this information, right? We're not, we should be getting this from our doctors. We should be getting this information really easily, but that's not happening.
Yeah. I mean, we deserve quality information. And all of the questions that I moderate in the month are not all about vaginal health, but
No.
many of them And it's definitely a top concern of women in postmenopause who have already reached menopause. They've gone 12 months without a period, and maybe that experience was mild to moderate. Maybe it was nothing at all, because that can be the case. But often they'll wake up in their mid to late 50s or early 60s, kind of surprised by this new experience. And that's what we'd love to talk about today.
Yeah. Well, and I was going to ask you, like, how often are those questions about vagina health? Because I know that a lot of women aren't comfortable talking about it. So do you find that women are getting a little bit more open and saying, like, hey, this is happening to me? Is this, and your space is a safe space to ask those questions?
There's definitely been a change on social media platforms as a whole, as well as I have a private online community. So I think women feel more comfortable if they can't talk to a girlfriend or a physician, healthcare professional, that they can talk in a private space where there are only other women. And they find out immediately. And you were referring to that show that we met at, Karen.
Mm-hmm.
That show was amazing because women came up to Kim and I afterwards. We sort of had this little buzz of attendees who wanted to talk to us after, and there were tears and there was gratitude, just because, not because of the information, although Kim and I are really good, but
Yes.
not because of that. They said the words they used were, "I feel seen for the first time. I feel heard." So imagine that you were sitting in that audience and you were having experiences, but you didn't know why. You thought you were the only one, and you thought that perhaps this is how you had to live out your next 4 to 5 decades. That can be really overwhelming.
Very
I
much
think it's
so.
interesting too, when Shirley first started her community, she will often say, she was thinking about the common things like hot flashes and poor sleep and brain fog. And she hadn't even thought of or considered vaginal dryness and painful sex. And that became quite a significant part of the questions that were being asked. And that was, I found her as she was just starting her community and fell in love with her right away. But then it just became such a natural opportunity for us to collaborate. Plus we live about 5 minutes from one another.
I know, that's so
enough,
funny. Yeah.
yeah. So it just became such an amazing way to collaborate specifically on those topics. And just given that it was such a huge part of the demand.
Yeah. I didn't know that it could get that bad. Like I had heard that, oh yeah, sure, when we get older, we might get some vagina dryness, but I hadn't heard anybody talk about it. And this was probably 8 years ago or something now. And I was with one of my daughter's friends' mom at my daughter's birthday party. And for some reason, this woman started to tell me her whole life story. And she said, my vagina closed. And I was like, what do you mean your vagina closed? She's like, it's just like, she's like, you can't get in there. It's shut down. It's so dry and it's done. Like my husband and I cannot have sex anymore. And I'm like, what? This happens? This can happen? Our vagina can close down? And then as I researched it and got more into this field of hormones, I'm like, oh, this is a serious problem. Like our vagina can atrophy. So let's start with just some basics anatomy. And I think, Kim, maybe you could share with us the anatomy of like what's going on with the pelvic floor as we age and what areas are being affected by the hormonal loss.
Yeah, the first thing that jumps to mind just before I get into the hormone piece is that person's experience is very common. And I want that person and anybody else listening who's in a similar boat to know that is something that is treatable. And it is, if you desire to have something inserted, if you desire to have sex with your husband or your partner or yourself, it's possible. Again, it will take some treatment, but there's hope there. It's not just like, as you say, closed up shop forever. And that's the end. We have to accept it. So the pelvic floor is a group of muscles that close the base of our pelvis. So if you think of landmarks in our pelvis, we all know when we get cross, we put our hands on our hips. Those are our hip bones, part of our pelvis. At the front, we may refer to the joint at the front as the pubic bone. It is actually a joint there called the pubic symphysis. The base of our spine, we have a triangular bone called the sacrum, and it forms two joints called the SI joint. So if anybody's ever had low back pain, they've probably heard of SI joints. And then at the base of the sacrum, we have our tailbone. The tailbone is also a point where the pelvic floor muscles attach. And then if you're sitting on your bum and you sort of wiggle around, or you lift up one butt cheek and pull the flesh of your bum away, you'll feel a bit of a bony point through the butt cheek. That's your sit bone or your ischial tuberosity, and you have one on either side. So the pubic joint, the tailbone, and the two sit bones are where our pelvic floor muscles attach, and they close off what would be the pelvic outlet. So if anybody's given birth vaginally, the baby comes through the vagina and comes through the pelvic outlet. And there's 3 layers of muscles. It's not just one muscle. It's not one group. It's several groups of muscles in 3 different layers that contribute to sexual response, to managing our openings, being the vagina, the urethra, the rectum, supporting our organs, the bladder, the uterus, the rectum, spinal and pelvic support and stability. So our core, if anybody's heard of core exercise and core workouts, the pelvic floor is the foundation of our core, and nobody's ever told us that. And it also works in relationship with our diaphragm, our breathing diaphragm, to move things through our body. So circulation, blood flow, lymph. And those are all really important jobs that I think we deserve to know about much earlier in life than in our 40s, 50s, 60s, when things are now changing and we're having some challenges. So it's a part of the body we don't necessarily see. So we can see our external genitalia, our vulva, but we can't see that group of muscles on the inside. And when things are working optimally, all those functions, all those things are happening, and we don't even think about it. But when they're not working optimally, it becomes one of the only things we think about, because that part of the body is so central to so many things that we do. And so the vagina is a tube, and we see the vulva on the outside, and on the inside, there would be the vagina that goes up and is held in place by the cervix and the uterus. And the walls of the vagina have folds in them called rugae, which are part of what contributes to our capacity for things to be inserted, for things to come out in the case of a vaginal childbirth. And as we are aging, and now estrogen is starting to not be supplied as much as we used to have before, we don't have it circulating as much, those folds can start to become less foldy, if that makes sense, less wrinkly. We have the best analogy I heard from a pelvic floor physical therapist was our vaginas are like pleated skirts most of the time. And as we approach and move beyond menopause, they become more like pencil skirts. So those beautiful folds start to thin and straighten and narrow, and the tissues become drier, which is that sense of things closing. And the term has been vaginal atrophy. Vaginal atrophy and dryness are sort of used interchangeably. And there's been a new term called genitourinary syndrome of menopause, GSM, which I'm not the biggest fan of the term for a few different reasons. That being said, it is encompassing more than just vaginal atrophy. So there's a lot of change that happens within the pelvic floor muscles, within the walls of the vagina, within the tissues surrounding the urethra, the bladder, everything. It needs to all be talked about. So I'm glad that there's a term that is bringing attention to more than just atrophy. Mm-hmm. And the term atrophy was always a bit challenging for people, but I think, as Shirley has said too, syndrome's also not necessarily the nicest word either. So anyway, that's the term we have. That's sort of what the anatomy is, the functions of the pelvic floor, just to kind of give people some landmarks.
Yeah. And I was saying to them before recording that when I saw that word, it was the first time I've seen that before. And I can't even pronounce it. So here we have a word that's challenging to pronounce, that doesn't really make a lot of sense when you read it. But at the same time, like you said, it's at least all encompassing.
Yeah.
But Shirley doesn't like it either. Do you, Shirley?
I don't. And I am a real stickler when it comes to words. So when I start talking with women about this, perhaps it's the first time they've heard about it, I don't begin with symptoms. I don't begin with suffering. I don't begin with syndrome. And the reason is I think that we all deserve a reminder that we deserve to feel amazing.
Mhm.
Like every woman on this planet needs that reminder, because we've been so socialized to expect pain with our periods, to expect pain with pregnancy, to expect pain with perimenopause, postmenopause, and we forget that we're actually supposed to thrive and feel well and get curious about anything. I will also acknowledge the fact that sometimes that journey towards amazing runs through a tiny little place called not yet amazing.
Yeah.
And those experiences can, run the gamut. But if we have great education, like your listeners are getting today from Kim and yourself, we're smart and savvy, we can figure it out, and then we can just get on with living.
Yeah, I had a
Same way.
client last week who messaged me, and she had gone to her doctor and said, I want an increase in my estrogen. And the practitioner said, no, I'm not going to give you an increase. You need to do as little amount as possible. You have to expect some suffering in menopause. Those were her words.
Yeah, I
You
know.
have to expect some suffering. And I was just like, you need to get yourself a new practitioner. You do not have to suffer. Do not let her tell you that. Like I was so sad for her that when she's like, no, I know, Karen, I need a new practitioner. I'm like, okay.
Well, I mean, maybe some more information and education. So
Yes.
estrogen therapy, localized estrogen therapy is one option on the menu that women can choose to prioritize their vulva and vaginal health. But it's not the only thing on the menu. So Kim and I think, we run through all of the things from sexual activity, if that's comfortable, keeping all the energy flowing to the pelvic floor, regular pelvic floor exercise, localized estrogen therapy if you are in postmenopause, as well as, and many of members of Menopause Chicks are using hyaluronic acid. And hyaluronic acid is an ingredient that most of us probably started to hear from the beauty and the cosmetic industry in 2008. It became popular to include it in skincare and beauty care. In 2013, it was shown to be as effective as localized estrogen therapy for the treatment of vaginal dryness. And then in the case of your client, I would say maybe, like many of the women, depending on her age and how long it's been since menopause, she might benefit from both moisturizing and using localized estrogen therapy. And then there are other treatments too. I always like to close out that menu by reminding everyone that not giving up. Like, do not give up. Do not go through one thing and go, oh, it just must be me, I'm alone. No, there are other available treatments such as red light therapy or laser therapy. Never give up.
No. And we're going to get more into the, solutions for this. But first, let's talk about what are some of these symptoms because it's a wide range. I mean, it can affect everything from bladder to sexual activity to just sitting, like painful. So tell us a little bit, like just kind of the list of what could a woman be experiencing when this starts to happen.
Well, I'll let Kim do the bladder, because she's the bladder and pelvic organ prolapse expert. But whenever I have these conversations, even with some of my colleagues who are trained in this area, the very first assumption that always comes up is that vaginal health equals sexual health.
Yeah.
And I'd like to clear up that myth or misconception. If you choose to participate in penetrative sex, sometimes even with a partner, that's your choice. But it's about so much more. It's about sitting comfortably. And we've both talked to women who cannot sit comfortably. They cannot go to yoga or dance or do the exercise that they want to. I've spoken with some women who can no longer wear jeans. or the
Yep.
clothes that they want to. These were all big surprises to me because, of course, I hadn't experienced it. So I was just listening to all the women in my community. And then, of course, you know, if you're experiencing any pain or dryness with penetrative sex, that's, you know, a check engine light and an opportunity to get curious. And then I'll let Kim take the other impacts.
Yeah. So some of the more common, you know, sensations that somebody may have could be burning, irritation, itchiness. Some of the pain, as I mentioned, that could be with just clothing, with underwear, with certain movements. There may be burning with urination. There is often an increased risk of UTIs, more commonly in people who already were or have been prone to UTIs. Increased bladder incontinence, so urinary incontinence, which is where urine comes out of the body when we don't want it to. So stress urinary incontinence is where you laugh, cough, sneeze, jump, and a little bit of urine leaks out with that exertion. There's urge incontinence, which is feeling like you can't make it to the bathroom in time. You have these sudden overwhelming urges, and sometimes you can have a complete release of the bladder. You can have a combination of those two. So these may show up for the first time around the start of menopause, or they may start to scream at you a little bit louder in terms of waving the flag and saying, I need some help. There's anal incontinence, so where gas or stool leaks out. So that's less common, but still something that we need to be aware of. Pelvic organ prolapse is where the bladder, the uterus, and or the rectum shift out of their proper anatomical position and they can bulge into or descend into the vagina. And early stage prolapse can often be asymptomatic. And there are many healthcare providers and physicians who deem early stage prolapse in especially people who have given birth and people who are getting closer to menopause as normal. That's the normal, quote unquote, normal anatomy. And as it becomes more pronounced or advanced, symptoms could be difficulty emptying the bladder, difficulty pooping, constipation, some discomfort with insertive sex, low back pain, a feeling of dragginess or heaviness, especially as the day goes on. People talk about wanting to almost like hold their vulva or their perineum. They feel like they need some counter pressure for some support, maybe challenged with certain exercises. So those are kind of the more common there. And then there's also pelvic pain. So pelvic pain is another kind of category under which painful sex, vaginal dryness could potentially be there as well. We have topics of vulvovaginal health just from a tissue perspective, but pain could be pain in the pubic joint, pain in the tailbone, pain in the hips, pain with insertive sex, pain with the thought of insertive sex, pain around the entrance to the vagina. Like there are so many different realms and sort of subcategories of pelvic pain as well. And sometimes as we again are approaching and moving beyond menopause, the changes in our hormones can exacerbate some of the feelings and sensations and symptoms we have. It could also be the time where they are showing up for the first time.
And how is it that the hormones affect it?
So in our pelvis, we have a lot of receptors. So you talk a lot about this, I know, in your podcast. It's like we have these little things waiting for the swimming estrogen to go by that it grabs onto, and it's very happy when it does that. When we no longer are producing estrogen, that estrogen is no longer floating and circulating around, and those estrogen receptors are not feeling very loved. And so the tissues then, without that estrogen to keep them plump and juicy and supple, start to again become thinner and drier, which can exacerbate or contribute to a lot of the symptoms that we just listed. So it's a lot to do with the decline and no longer having that estrogen circulating. It's also, we don't have as much collagen. We don't have as much hyaluronic acid. We are losing muscle mass. Something called age-related muscle loss is called sarcopenia. So we are all losing muscle mass as we age. We also have our bones to consider. And when we are, our scaffolding is also being influenced as we're aging and knowing that we lose a significant amount of bone in the first 5 years post-menopause, we have to consider where our muscles are attaching, and do we have a strong scaffolding as well? So hormones are a piece of it, but we have to consider all of the other things as well.
Do we know whether or not having a hysterectomy affects the pelvic floor and also the dryness part of things?
1000%.
Oh, okay.
And this is something that is not typically discussed when people are having. So hysterectomy is second to cesarean birth as the most common surgery performed in the United States. 600,000 per year are done. And often for benign conditions. And I want to say that there is no shame in having a hysterectomy. There are many reasons for a hysterectomy. What I hope in people listening to this podcast, and as the world becomes more informed with regards to pelvic floor physical therapists, is that the uterus holds the top of our vagina up. It is like a keystone organ in our pelvis. When it is removed, it leaves us a space or a void. We need to ask questions and be curious about how is the vagina resuspended or held up now without the vagina without the uterus and potentially without the cervix there. And so that increases our risk of pelvic organ prolapse, which I talked about is the shifting of organs. The intestines can often start to descend into that space. Potentially the bladder now can more likely. So especially in people who had a hysterectomy for uterine prolapse. So if that was the main contributing reason for them having a hysterectomy, the already increased risk of having a pelvic organ prolapse after hysterectomy is even more increased. And part of that is because we're not addressing root causes. So what are the reasons why that uterine prolapse happened in the first place? Constipation is a big thing. Hormones is a big thing. Posture, exercise, lifestyle, childbirth, like so many different things that we need to look at. And sometimes it is not repairable with exercise or with hormone therapy. And again, it can be a viable option to have that, but we need to know that increased risk and what we need to do then in preparation for that surgery and also afterwards to help mitigate those increased risks. And we also need to know that even if somebody keeps their ovaries, there's now some evidence showing that there will be an earlier menopause for that person. And so counseling and information shared with regards to the hormonal influence, because a lot of people say, well, oh, don't worry, you're keeping your ovaries, you'll be fine.
Yep.
And there may not be that immediate disruption that somebody would have when their ovaries are removed right away and putting them immediately into menopause. Excuse me. But we need to have conversations. We all need to have conversations around hormonal health anyway, but especially when the uterus is involved.
Oh, I know. It is so overperformed, like you said, that surgery. And yes, sometimes it's very necessary and I can get on board with all of that, but it's like when the doctors say to these women, well, you're not having babies anymore, let's just get rid of it.
Yeah.
And that's not getting to the root of the problem most of the time, right? If you're heavily bleeding and they're like, let's just get rid of it.
Yeah.
There is consequences to it. We're taking out an organ.
Yeah.
And
there's some data that we want to pay attention to with regards to brain health. So having a hysterectomy prior to the age of 45, if I'm remembering the data correctly, is showing potential influences to our brain health as well. So that's another factor that we want to consider. And then the other final thing I'll say is sometimes having a surgery for, say, a prolapse, which removing the uterus for that prolapse, it then unmasks incontinence. So that prolapse actually can sometimes provide a little bit of pressure against the urethra, which can then mask incontinence that is actually there, but we don't know about it until that bulge is returned. So people get some symptom relief from having a hysterectomy, but now they're faced with another challenge. And even if it's not right away, it's something that can often develop is incontinence afterwards, because now we have scar tissue. And again, we have changes to the way the muscles are functioning. Surgery can kind of sometimes well, it does in this case very much change anatomy, but sometimes it can reestablish anatomy to some extent, but it doesn't address the function. And that's where exercise and pelvic floor physical therapy play such an important role in this whole conversation, to make sure that we are not just, removing this one symptom and now people are faced with another that again are told, oh, it's just what happens when you get older. Oh, it's just what happens because you've had babies or because you're approaching menopause. So
Yeah.
I think, if I could add to that too,
Yeah.
I would just say that women not talking contributes to this social construct as well. So we live in an age of misinformation. We all know that. But the fact that the notion that, oh, I had a hysterectomy and all is well, right? That notion has spread through the last few generations, and it's created this space of, oh, I had my uterus removed, so now I don't get a period, and everything is great. And what we've failed to insert, and that's why I love that Kim just used the word counseled, is that we've failed to educate and inform women the role of estrogen and progesterone. And if now you've had your uterus removed, you no longer have a period, you don't have that sign every month, that health indicator, you're not aware of when your estrogen is going to go for a decline, which happens post-menopause after you've gone 12 months period free. So you're completely unaware that you could be facing a future of vaginal dryness from atrophy, incontinence, and all the other things that we were talking about. So it's this huge void that we're trying to bridge.
I listened to these two male doctors talking on a podcast, talking about how hysterectomies are just overperformed and they're trying to change this. And he said, could you imagine if we did this to men? That if every problem that they had with their genitals, the answer was, let's just remove your balls.
Yep.
He's like, we would never do that. So why are we doing this to women? And I was like, oh, bless you guys. Like, thank you. But it's so true.
It's so true. And it's actually worse than that. We remove body parts from a woman and then we say, just drive around for a little while and see how you make out, and, come back in 6 months and see how you feel.
Yeah. Yeah. And women aren't told that their ovaries do begin to atrophy sooner, typically after they have a hysterectomy, even though the ovaries are left behind, and they're kind of told like, oh, as long as your ovaries are there, you're fine. Yeah. And that's not the case for a lot of women. No. So, and do we know whether or not if does it affect sexual pleasure, not from touching, just like orgasms, like when the dryness starts to happen and we're losing, what did you call those folds again?
The rugae.
The rugae, yeah. The skirts. we're now a pencil skirt. We're no longer pleated. Is this affecting the amount of pleasure we could receive, like with clitoris stimulation? Do we know that?
I don't know of anything that suggests that if we don't have as many folds, if we have vaginal dryness, that it will influence, like that it will change our capacity for clitoral orgasm. Yes. That being said, the clitoris is part of our vulva, is part of our anatomy, that can also face change without circulating estrogen, and clitoral atrophy is a thing as well, clitoral adhesions. And so that's not its own separate little thing that just sits up here and it's untouched. It's absolutely influenced as the rest of the tissues are. So, and post hysterectomy, depending again on, how they've resuspended the vagina, that there can be almost like a little bit of shortening of the vagina that can, for some people, create some discomfort with insert of sex. Some people do talk about difficulty with orgasm after. So we need to, again, do some digging to say, is that because of a hormonal influence? Is that because of the sense of loss? There's a lot of loss that people feel when they have their uterus removed from their body. So is there a grieving that's maybe influencing some of how they feel, whether that's, I feel, these are words I've heard, I feel like I'm not a woman anymore. I feel like I'm not a sexual person anymore. So there's a piece there. Is it also the scar tissue that has remained after, which we need? It's a part of the healing process, is to have some adhesions and scar tissue, but that can sometimes interfere with blood flow and circulation, maybe even entrap some nerves, influence how the muscles are functioning. So our capacity to achieve orgasm, we need good blood flow and circulation and muscles that can contract and relax. And if we are in a state of contraction with those muscles, which is very common, especially people who've had incontinence and or prolapse, who are kind of on guard thinking, am I going to leak? Is something going to fall out? There's unconscious guarding that happens. And that heightened state of alert almost in the muscles means it's impeding the blood flow and the circulation, and also the capacity for that kind of ebb and flow we need for pleasure and for orgasm.
Yeah, I thought so. Even just from my own experience, like I noticed that definitely when I started to get a little bit of vagina dryness as I was going through perimenopause, my orgasms became subpar. And I'm sure that had to do with because my estrogen and testosterone were lowering, which will affect sexual pleasure. But it those two things happened around the same time where I was like, that wasn't that good.
Yeah.
That was kind of like, ooh.
Yeah.
Like it was like, oh. And now
it-
it's like way better now that I'm on estrogen and testosterone and that I don't have that problem anymore. And now they're better than ever, but still, it
with
seemed
or
like it
without-
happened.
With or without a hysterectomy, we have to remind women that skin is skin. And so while we have a tendency to talk about the vagina, that's just the internal skin. So if you are experiencing dryness internally, vulva dryness, you're probably experiencing like drier eyes and drier skin too, because we haven't had that full education of this is what estrogen, like the role of estrogen in our whole body. This is the role of collagen. This is the role of hyaluronic acid. And we sometimes like isolate the vagina as if it's just all happening in a vacuum, and it's not.
No, it's lubrication everywhere.
Yes.
Joints,
Mouth,
eyes. Yes.
joints. Yes.
Yeah. Very important, I think, for women to know that these things can all start to happen at the same time for the same reasons, that lubrication starts to go downhill, right? And is hyaluronic acid, is that also important for all over lubrication?
Yeah, absolutely. So it's a naturally occurring molecule that our body makes on its own. Unfortunately, it starts to decline in our 30s and 40s, and then it goes for a steep decline post-menopause. At the same time, estrogen goes for a steep decline. And it's funny because I think that our society likes to think of these external things, and we don't even realize that it's something our body used to make on its own. So we need to give our body back. And, you can get eye drops with hyaluronic acid in it. You can take hyaluronic acid orally. There are a lot of joint therapies, like for knees and hips and so on, that you inject hyaluronic acid. And then, of course, as I said before, hyaluronic acid can be used as a treatment for vaginal dryness.
Is there any connection between estrogen and the production of hyaluronic acid?
Well, just by age.
Yeah. Okay.
That's the connection. Lots of these things overlap and happen at the same time.
Yes. And, this is all, whenever I talk about these things that start to happen to us in perimenopause and menopause, I can kind of feel like a little bit of doomsday, that like, oh God, now, and I'm going to have to deal with this too. Like, but this is the whole point of these conversations, is so that you guys are arming yourselves with some really great tools so that you don't have to experience this and you don't have to have the doomsday. Like, we can avoid all of these things. And this is what we're doing, is getting the word out there so that women don't have to suffer and that they can enjoy these years, which can be the best years of your life. Like, always remember that. So let's talk about some of these solutions that we can, start, helping ourselves with, so that we can prevent it, and also we can reverse it. Because like you said, Shirley, this is reversible. We can do this, right? It doesn't have to be a lifelong thing.
It can be prevented and it can be treated. So remember that. And I get the doomsday concept, but don't stay in that place for too long is my best tip. And we never get mad. All three of us, I think, we live in Canada, right? So if you have a car and you drive it for 100,000 kilometers, You don't turn to your car and go, oh, it's doomsday. You say, oh, I want you to drive another 100,000 kilometers. So I'm going to invest. I'm going to invest in making sure that that's a vehicle that can carry us forward. And that's exactly what Kim and I try to talk about all the time too. This is an opportunity to invest in our health.
Yeah, and that there is things that can be done. It's not that like throw in the towel and, well, I guess this is just part of aging, and do not do the I'm going to suffer through it. That's not the right attitude, if you ask me.
No trophy for that.
No trophy. And I hear women say, at that conference that we went to, a woman said that to me. She was like, "Oh, I'm not going to do hormones. I'm going to go through it naturally." And I was like, "Oh my God."
Yeah.
Okay.
Well, hormones are they're naturally produced in the ovaries.
Yes.
They're regular. Okay, so I'll let Kim go through the whole menu. We say that we sing off the same song sheet. But if I could just start and make sure that everybody understands the difference between a moisturizer and a lubricant.
I was going to ask you that.
One of the solutions is to moisturize your vagina and your vulva. And a moisturizer is, as we were just discussing, an investment in your skin health. So it's something that you apply away from sexual activity as part of your regular moisturizing routine. Moisturize your face, brush your teeth, moisturize your vagina.
And it's not coconut oil, right?
And it's not coconut oil.
I heard you say that.
So coconut oil is interesting because I do know that that recommendation does come from some healthcare professionals. Food oils in general have never been tested on the vagina, but there's really no indication that would make us think that they are risky in any way. But oil does for your skin what it does in the frying pan, and that is it provides a barrier to friction. So if that is your lubricant of choice, and a lubricant is exactly that, it's a barrier to friction, then fill your boots if you like coconut oil. But you use that for pleasure and fun, for sexual activity. There is no long-term moisturizing benefit from food oils. So you need to be moisturizing with something that's approved to be on your vulva and in your vagina, like a moisturizer with hyaluronic acid, and then use lubricants for pleasure and fun.
Yeah, two different things. Very important. Yes. Okay.
Yeah. So for me, I always, whenever I'm asked, what can I do? My number one piece of advice is always to book in with a pelvic floor physiotherapist. If you're in the United States, they're called physical therapists. So it's the same thing. And many people often wait for years, suffering for years. Maybe they've asked for a bit of help, but they're told it's normal, or that it's just this and you have to suffer. All the messages that we've talked, that does happen. And those people then, when they finally seek help, are seeing their family doctor, which, as we know, not all doctors are up to date with the latest research as it pertains to the changes, the genitourinary syndrome of menopause, hormone therapy, hyaluronic acid, any of the things that we've been talking about. And so that person could potentially be offered medication, maybe sent to a specialist, which are not necessarily bad things. They are options that we have, but I don't believe that they should be the only options offered. And in my opinion, our best first line of defense for pelvic health, vulvovaginal health, is a pelvic floor physiotherapist. They are experts in the pelvis. That's what they do. They are licensed to evaluate and treat externally, internally with gloved fingers. They assess for function. They can look at the status of the tissue, because there are also skin conditions that can mimic some of these, the burning, irritation, discomfort within sort of sex symptoms that people have, but it may not be vaginal dryness, may not be just vaginal dryness. It could be something else, like lichen sclerosus is something that's very common. So having somebody who can screen for and then recommend medical assistance if needed, I think is really valuable. And I always say also that we've been conditioned from a young age to brush our teeth twice a day, floss, go see the dentist once or twice a year. And we go, even if we have no toothache, nothing saying that we have a problem, we just go for our checkup. And I think we need that exact same PR for our pelvis from an earlier age, when we are first teaching teens about body health, menstrual health, sexual wellness. Introduce what the pelvic floor is, how we manage it through all of the changes that we go through as women, and plant that seed that pelvic floor physiotherapy is something that we do on an annual basis. Even if we have no symptoms, we just go and we have our checkup. So that's my number one thing. The next would be, if there are, like, I think everybody would benefit from moisturizing their vagina. Shirley has a great one called Feel Amazing, which I also love the title of. That's something that we can start at any age. And I think again, it's a practice that is beneficial, that is just something we need to adopt just as we're using a face serum or body moisturizer. Then we can have conversations around, so when we're talking about sexual wellness, we talk about lubricant, which we've already said, which is to reduce friction. So that's another piece. And then we've had the conversation around estrogen. So around the start of menopause, estrogen is something that may be beneficial. Earlier, if symptoms start to show up, early postpartum is also a time where we have drops in estrogen, where vaginal dryness can start to come into play. And we also want to look at other things that can contribute to dryness, which could be medications, could be lack of blood flow and circulation, could be pad use. So the people who are wearing pads, who are told by the media that it's just part of being a woman and that we should accept it as normal, could also potentially be exacerbating the vaginal dryness that they're experiencing as well. So doing some screening, and pelvic floor physical therapists can do this. I do this in screening when I'm working with people as well. I know Shirley does in her work as well. So again, just asking questions and having conversations and trying to sleuth out what could potentially be contributing to some of the challenges that person is facing. Then we have pelvic floor exercise. So everybody's heard of the term Kegels. Kegels are evidence-based. They work when they're done correctly. They work when they're done consistently. But the majority of people are not doing them correctly, and also then not doing them consistently because they think they don't work, because they haven't been doing them correctly. And that's not their fault either, because nobody's taught them. Nobody's evaluated their pelvic floor. So again, plug for pelvic floor physiotherapy. They are the gold standard in terms of you understanding and learning how to contract and relax your muscles.
You taught me that, Kim. Taught me how to do a proper Kegel in our first conversation. I was like, oh, I am not doing those right.
Yeah, most people aren't. Again, we think like it's, we squeeze our butt or we squeeze our inner thighs. Sometimes we bear down and we think that we're accessing this group of muscles, but it's really quite a subtle part. It doesn't need to be thinking about lifting up pianos with your vagina either. That's why where the blueberry cue comes in. It's just really a subtle activation and relaxation. And the relaxation piece is often what's most overlooked, because people think that, well, if I'm leaking, or if I'm experiencing these sensations of heaviness, or if I don't have pleasurable sex, that must mean I'm weak. Weak means I have laxity, so I need more Kegels to strengthen and add more tone. But we can have too much tone, which contributes to weakness. So a lot of time, people who have been leaking, people who do have prolapse, as I mentioned earlier, they have that kind of on guard, high alert group of muscles that aren't relaxing properly. And so it seems counterintuitive, but a big part of optimizing pelvic floor function, yes, we need Kegels, but we need to remember that Kegels involve a relaxation component as well. It's not just about a squeeze. There's a lift. As
tight as you can for as long as you can.
Yes, exactly. And we need that practice as part of our day. And I think another missing piece, and we're starting to see some evidence for this, is when we bring those pelvic floor Kegels or pelvic floor activations into whole body movement, we're seeing more benefit. There was a doctor who I worked with, Dr. Bruce Crawford, who is a urogynecologist, and he's performing surgery, and he says, okay, I performed surgery on this person X number of years ago, and here they are again. I'm a good surgeon. Why is this happening? Why am I seeing these people coming back? So we haven't been addressing root causes. And he looked at it and from a fitness and movement perspective, and looked at wireless EMG recordings of the pelvic floor, the inner thighs, the glutes, and the deep abdominals, and looked at 150 different exercises. Where in those exercises was the pelvic floor most engaged? And he narrowed it down to a top 10. And then within those, he said, all right, well, I see where in, let's say, the squat, that was one of his top 10. in the squat, the point of peak engagement is just before, kind of just as we're standing up from a squat. So we lower down, the pelvic floor is lengthening, and then just before we stand up, it contracts. So if we add a voluntary Kegel to that part where there is the peak engagement, do we see more? And he was showing, and I went down and got hooked up myself and saw the same thing. And I also saw when I incorporated it with the breath, which is what I do, it was even more. So getting more bang for your buck is important. And just sitting at every red light and doing Kegels is not going to ever be effective. And one, because red lights aren't that long and we get distracted. We're not in the right position. There's lots of reasons why. But when we can incorporate our Kegel practice into whole body movement, we're already doing that workout. So yay, we're killing two birds with one stone, and it's more functional in training the pelvic floor dynamically. So those are kind of the top things there, along with what Shirley was talking about. We need the muscle is a tissue, but we also need that tissue support with lubrication, with hyaluronic acid, with estrogen potentially. We also need good blood flow and circulation with the exercise, and we need our practitioner to screen every year to make sure that things are staying optimal.
Great. Yes. Shirley, did you want to add anything to that?
No, she's a rock star. That was amazing.
Yeah. I'll add the different options that we have actually as bioidentical hormones and how you can apply them, because a lot of women don't know this, but compounding pharmacies are amazing people. And they can put it into a cream. I know that I interviewed a compounding pharmacist, and he puts, every woman that has the dry vagina, he's got this amazing cream where he has a little applicator, and he says, I just find that that's a lot easier to apply, especially if they have a lot of atrophy going on, because you can do things like suppositories as well as something called an E-string, which is a little ring that you can insert up into your vagina, and it releases a little bit of estradiol locally. But he's like, that can be really uncomfortable to try and get that up there. So for some women, it's just easiest, he said, to apply just directly a safe cream that's bioidentical estrogen, typically estradiol, right up inside. And he says that he finds that works really, really well. You can also, I know when I was put on, when I started my testosterone therapy, I was injecting it with just these the empty needle, little syringe things. And that's where I applied my testosterone, and it did an amazing job at bringing lubrication back in. And it can also be used to actually strengthen your pelvic floor and your bladder. There's some therapies that some doctors are using where they're directly putting testosterone. I even heard of testosterone injections, but I don't know how that worked, but this was a doctor that was using them to help with women with incontinence, and it was having a lot of success with it. Not sure how that worked though, so please do not try this at home.
Yeah, even Botox can be injected in and around the bladder, and there's the O shot, which is using PRP. So if anybody's, again, we refer back to the facials and the facial therapies we have. If anybody's seen the vampire facial, there's lots of PRP injections. So PRP is platelet-rich plasma, where there's a blood draw. Our own blood is put into a centrifuge, and it spins, and it separates out the plasma, which is then re-injected into the body. And in the vagina, the O shot it's kind of a marketing term. It's mainly geared for increasing sexual pleasure, and is injected into the front wall of the vagina, close to the urethra, and then also up at the clitoris. But I also know off label where this is happening elsewhere to potentially help with increasing some kind of plumpness and some where we've had some atrophy. Maybe is it an opportunity there? So, which I think is amazing. So yeah, we can have injections anywhere. It doesn't sound super
I know,
pleasurable, but a lot of people say it's really not that. It shouldn't be that really uncomfortable. And there are local numbing creams that can be used as well. And with regards to the estrogen, there's lots of different applications for it. we can use our fingers even to apply cream. But there is also sometimes PTSD for people when touching their own bodies. And so applicators can be great. E-strings, yes, they can go up and be inserted and left alone, but not everybody has the capacity to have something inserted right away. So maybe they are working with a pelvic floor physiotherapist and using dilators to help increase the capacity of that tissue again in conjunction with estrogen therapy.
That's good to know. Yeah. And ladies, estrogen, when you're putting it on your skin as estradiol cream or biased, or you're doing patches, that does eventually get down into the vagina tissue. And I always tell my clients that, if this is something that is bothering them right now, I definitely find that using something locally at the same time as replacing their estrogen, maybe on their arms or through a patch, for a period of time while we get those estrogen levels back up again. And then a lot of women don't need to continue with the direct application of it to their vagina. And some it'll make its way down, and the lubrication will come back for a lot of women. I've had women say to me, I feel like my vagina's coming alive again when they start estrogen therapy, not in the vagina, just topically on their skin. So that is something that happens. So keep that in mind too. There's also DHEA. There's a lot of products now, over-the-counter products in the United States that have, I know that Dr. Anna Kabeka has a really good one called Julva, and you can put that on inside and on the outside of the vagina.
Is now approved in Canada as well.
Yeah.
What is, sorry?
Intrarosa.
DHEA is approved in Canada now as of November 2022. The brand name is called Intrarosa.
Okay.
And then there's another new treatment that's actually an oral treatment for vaginal dryness. I know, I try to make the connection. Take it here and it finds its way to the vagina, but it's another option for women, which is really exciting. When you think about how you opened up this podcast with the stats and the big gap that we have between the number of women with this experience and the small number of women who have a easy, viable treatment. And I've spoken with women who often localized therapies are prescribed to apply at night. And if you're exhausted, if you're having trouble with sleep, and you might go to sleep and forget it, and then you're not sure what to do the next day, it can be very confusing, cause anxiety. Whereas a lot of us are it's more habitual to take oral medications and supplements in the morning. So if you can add that to your protocol and it actually makes you more compliant, then the outcome is better. So it's just really exciting that there's a lot more options available for women.
Are those prescription?
Yeah, it's called Osphina.
And what's in it?
Osphina is the brand name.
Okay. And is there a hormone in it? Osphina?
Osphina.
Does it contain DHEA?
It's not DHEA, and I'm not going to speak just in case I get it wrong, but I'm happy to get back to you on that.
Yeah. Okay. I can always put it in the show notes too, like link to it. Because if that's here in Canada,
then
then
exciting for a lot of different applications as well, because when it's applied to the vagina, it actually only distributes the amount of hormone that a woman needs. So it's kind of like this magic formula that goes on, and I think that's really exciting. And it's been approved in the US for years, so it's great that Canadians now have the same options.
Yeah.
Yes. Yeah. And estriol, we talk about estradiol, but estriol, you guys have heard me talk lots about in this podcast about estriol, and it's mostly present in the vagina tissue. So it can be a really good one as well to use if you're experiencing vagina dryness, especially if you have a history of breast cancer, because estriol is breast protective. It only sits on the beta receptor, so it does not create growth. So that's
and there was also a paper that came out by the North American Menopause Society late last year as well that showed that women who have experienced breast cancer can continue to use localized estrogen therapy as well. There's no need to discontinue it. Which is really exciting.
That's very exciting. Yes. I'm really trying to change that conversation as well. Okay. And one laser therapy and nitric oxide. What about those two?
So there's, again, coming back to medi spas, and we are investing in all sorts of laser therapies and what have you for our skin, for wrinkles and anti-aging, and a lot of the same technologies can be applied to the tissues in the vagina as well. Red light therapy is something that we can do at home even, which has some benefit for reduced inflammation, tissue healing. An amazing product I love is called the V-Sculpt. If you're in the United States, it's called the V-Fit. It's the exact same device, just Health Canada versus FDA naming them. And this is using red light therapy, infrared heat, and sonic vibration for the increase in blood flow, lubrication. I have people use their Kegel exercises while the vibration is on, so we get a bit more recruitment, similar to those vibration platforms that we use for exercise in the fitness realm. So I really love that. Then there's the more elaborate lasers and light therapies, and there are so many now. So many different medi spas are offering therapies. Vaginal rejuvenation is typically the terms. Some of them are radio frequency, some of them are light therapy, some of them are lasers. So do your research on the clinic and on the actual therapy they have, and look in PubMed for published studies. One of them that has a decent amount of evidence is the Mona Lisa Touch. And this is a bit more of an ablative laser, and it's essentially creating micro injuries to stimulate the production of collagen. And there is some indication for the use for dryness, potentially for atrophy, again, if the wand can be inserted. There's some, it's not indicated necessarily for incontinence, but some people do notice an improvement with incontinence as well. Viviv is another one. So that's radio frequency, and that's using heat to penetrate deep into the tissues. There's the Diva. There's, like, I could name so many different ones. And I will say, do your research to make sure that Thermiva is another one that's coming to my mind. Diva is a kind of a hybrid almost, where it has a little bit of the ablative laser and then a little bit of the heat, but there's also some cooling in there. So I can't actually, I have had a Viviv treatment. So there was a practitioner who had asked me to review it. And while it was difficult for me to review because I didn't have any symptoms that it is supposed to be indicated to help with. So I said, I can speak to like what it feels like to have a treatment. It was very pleasant, actually. It was just, it felt like I had a lot of heat, not in a bad way, but just like warmth in my vagina and around
little
my vulva.
vagina.
Yeah. So I didn't necessarily notice a change, but there wasn't necessarily change at that time to happen. So that's the only one that I've experienced myself. But I do think that there is some evidence for some of them, not all of them.
Okay.
So do your research. You want to understand the provider. How many have they done? What's their success rate? Look at PubMed for the published research on that specific type of therapy. And yeah, so Thermiva, Viviv, and Mona Lisa are, I would say, the ones that have been around the longest and have some evidence to support. And there's a few others that are coming around that I think, again, amazing technology. I'm glad we have them. I don't think that should be our first option.
No, because it's not going to the root cause.
And it's also expensive, and it's not a
Yeah.
lifetime. It's not like it's a lifetime cure either. So they can be a modality, but they need some upkeep, just like the stuff we do for our face needs some upkeep as well.
Yeah. Yeah. I've seen some hormone clinics around this area that offer it in their clinic. So
Yeah.
it's definitely out there, but I just think
the best way to separate it out for your listeners is bucket number 1, prevent. Moisturize, see a pelvic floor physiotherapist, practice your regular pelvic floor exercises,
replace your hormones.
right?
Don't wait till
And
the bitter end.
Bucket number 2 is understanding the role of your hormones and having a plan
Yep.
for when your body no longer produces them in the same quality and quantity it once did. And bucket number 3 is don't give up. As Kim just explained, there are lots of other options. If you have gotten to a place where you're suffering, it's maybe been a long time since menopause, maybe you got some misinformation and when you were going through breast cancer, there's, we do have a segment of the population that needs to know that there are options available.
Yeah, good call. Yeah, definitely. And your product, Shirley, so it is, you had a pharmacist create it. Is this over the counter?
Yeah, so it's non-prescription. Hyaluronic acid was approved in 2013 as a viable treatment for vaginal dryness. In 2021, the International Society of Gynecologists recommended it as the first line of defense for women. And so we had already compounded hyaluronic acid with a little bit of vitamin E. And now this product is approved by Health Canada and has its own NPN number, natural product number.
Wow. And do you ship to the States?
Yeah, we ship to the States and we ship around the world, actually.
Oh, I'm going to get
And
some.
it's an awesome product. I've been using it for several years and I love it.
Thank you.
Oh my gosh.
So have I.
I want to use it.
It's called moisturizervagina.com is the URL.
Perfect. Yeah. And when we were at that conference, there was a booth that was set up right to next to where you guys were talking. That's also two women from BC again. Yay, BC, that have just started a company with a natural vagina lubricant, not a moisturizer, a lubricant. And I bought that and that's been awesome. I really like it. So
yeah.
And it's
Yeah,
all clean, like there's nothing, no crap in it, which
Yeah,
when you're putting
yeah.
things there that you want that.
Yeah, Okanagan Joy or OK Joy, I think they're calling it. But yeah, they're doing amazing things too. So
I'll link to their company as well, because that's a great solution for lubrication. And then you guys have it all for the vagina. And by the way, Kim, like the name of your podcast and your app, could it be any better? Like it's seriously Between Two Lips. I read that. I was like, oh my gosh, I love that so much. Why can't I find a really great name like that? And the Buff Muff. That's why when I first came to you many years ago, it was that app name. It was I saw you talking about having a Buff Muff. And I'm like, I want to have a Buff Muff. I want this woman to come talk on my show.
Well, and we need, like, as much as obviously I'm comfortable with the word vagina because that's my whole brand, but we also need to have some fun with a difficult conversation, things that make us feel uncomfortable, so we can have a bit of a laugh. And so while I totally support using proper anatomical terms, I think we can throw some fun in there too.
I 100% agree, right? Absolutely. Like this can be all, like I said before, it can be a little like, oh, let's have some fun with it. We know that this can be some of the best years of your life. So you guys don't suffer. And get that we have gone through so many things today that can help prevent this and also reverse it. So please check these things out. I'm going to link to everything in the show notes. Thank you, ladies. Thank you, my fellow Canadian, British Columbian, amazing women that are helping perimenopausal and menopausal women.
Likewise. Thank you for having us.
Thank you for having us.